This is Dr. Lumsden. I'm here with Dora Zachko. She's a 4th year's general surgery resident, or vascular surgery resident at Semmelweis. So we're going to start off by doing a midline incision from xiphoid, coming around the left side of the umbilicus, all the way to the pubis. Where's the bovie? Oh yeah, thank you. So typically we'll have 2 bovies, but we're just going to make do with 1. And I'm going to start off with the incision. We're going to usually bring it all the way up to the xiphoid, and Dora's going to be a little counter traction there. I'm going to give her the bovie. That's all right. We're good. Yeah, thank you. So scan subcutaneous tissue. Actually, give me the other bovie. That's a good idea. This is kind of how we normally do it, is with 2 bovies. So we're going to get the skin medicine, and now basically follow down. We're trying to stay in the midline. We're looking for the linea alba. I use my fingers to spread apart here. All right, got it all open. Go ahead, you go down and I'll follow you. Yep. All right, Dora, so come on up here. So we're looking for the linea alba. Looks like we already hit it. So that's in the midline, right angle. So again, safest place, we're going to try and get into the retroperitoneum. Some people do this by picking up a couple of hemostats. Here we can see if you can grab another hemostat. You're supposed to do this with scissors. And we see if we can get into the peritoneum. Lifting up. And it looks like we're in the peritoneum, so go ahead and put your finger in there. Go superiorly. Are we in or are we pre-peritoneal? So take the bovie on your finger, go ahead and open that up. Looks like we're in. Come on up. Now let's say we're going to do suprarenal exposure. So I would say that if we're going to do that, let's just demonstrate this. I would typically come around the xiphoid, and sometimes we're going to demonstrate taking the xiphoid out, but it always bleeds. So again, I know that I'm going to use suprarenal cross clamps. I need as much exposure as I can potentially get here. So I've got my fingers in here, and now we're going to come around the xiphoid, and almost always a little bleeding vessel alongside the xiphoid that we got to get. But this allows you to get maximal exposure. Now you're getting pretty close to the undersurface of the heart when you're doing something. Go ahead, you get the deeper part. And so that's the xiphoid being exposed. Yeah, so we're typically going to cut this off because it's usually cartilage. And then what happens is there's always a little bleeding vessel that you got to get alongside this. You just got to be, and we take it off. Usually bleeds up there. Get rid of that. Gets us a little bit more exposure. So now we should be getting pretty close to the undersurface of the diaphragm. Probably could have taken a little bit more. So the diaphragm's still actually up there just a little bit. Once you get retraction on it, we'll see. So let's go on down. Put your fingers in there, lifting it up so you're essentially looking down inside. Make sure that there's no adhesions to it. Your finger on your side. I'm looking down. I'm going to open the midline. Trying to stay midline in the linea alba. Remember, halfway between the umbilicus and the pubis, there is no posterior sheath. So I'm getting a little bit out the midline. And so one of the things I always do when I get down, we're coming down to the pubis. This is kind of where things start coming together. I always get my finger in that pre-peritoneal space. You're going to make sure there's no bladder in there. And now, this is kind of where I use the Balfour retractor. And so it's just so I can get exposure to start with. So there's some adhesions there, Dora. I don't know what this is. So again, techniques in taking down adhesions. If you can see through them, you can cut them. Okay. And you can't get into the chitlin here. I mean, the chitlin is the bowel. Otherwise, case is over. So you're always spreading with your fingers, trying to see if I can see through it. Obviously, that can come down. So Dora's doing the right thing. The art of surgery is traction and counter traction. Now, I'd be a little slower if the patient was alive. So, now, a lot of people when you do this will take down the falciform ligament, the ligamentum teres. There's the falciform. I don't think we need to do it here, but that's a falciform ligament. I don't think that's going to tether us. The reason for doing that is sometimes you worry about the liver being torn. So there's opening up the falciform ligament. Ligamentum teres is there. Let's just go clamp and tie it. I'm going to clamp, you clamp the other side. I'm going to bob it. And then we're going to tie it off. So tie this up. See if you're any good. Don't be nervous. Whole future may depend upon the next few minutes. Scissors. And again, yep. 2, 3, good. She's going to tie, take another one. Typically if you've got a scrub nurse, you'd be holding your hand out, she'd be loading that while I'm cutting the tie. Okay, so the technique here is that we are going to fan out a towel. I'm going to lay it across here. Now go ahead and grab the omentum. It's the first thing you look at, huge omentum. So we need the omental flap, beautiful omentum. So go ahead and take the omentum, lift the omentum up, and we find out if it's stuck anywhere. So it's stuck, we got to take those adhesions down. I'm just going to cut through these. Normally I do this with the bobby. Okay, so you need to get the omentum mobilized so we can get it up. I typically tuck this underneath the superior margin and then wrap it around, wrap the towel around. Take all the small bowel out from down here, a little juicy. Take another towel, fan it out longitudinally. Tuck it underneath the abdominal wall. Good. And then go down to the left lower quadrant, take all the bowel out. Yep, so there you go. So sigmoid colon ligamentum teres ideally stays behind. Small bowel is out. Beautiful demonstration here. You're going to tuck all that in there, just like that. Now you're looking at the duodenum, okay? And so I usually do this dissection before I put in the big retractors. So you're going to lift up, and we're going to mobilize this. So again, staying in the midline. Midline should be where the aorta is. Normally we'd feel a nice pulse in it. And you're going to put it up opposite me. So this is the DJ flexor we're looking at. So use your finger to sweep that back for me. Perfect, beautiful. Yeah, lift up that little adhesion for me if you would. Yeah, there you go. And then use your finger to gradually mobilize that back. Some staining back here in the retroperitoneum. Shouldn't be. Maybe the aorta's ruptured. Who knows? Let's mobilize this. Again, doing the same thing. Now you're going to roll that retraction in a little bit more. And so that's probably the inferior mesenteric vein here. So I think the aorta is right there. So often we've got to take the inferior mesenteric vein, so we're going to demonstrate doing that. So I'm going to take my right angle clamp, or any kind of clamp. See if you can grab another clamp. We're going to clamp the inferior mesenteric vein, and then we're going to divide and tie it again. There we go. Yep. So inferior mesenteric vein is divided. That should take us down the aorta. I got it. You go ahead and tie it. Good. So this is ligating the inferior mesenteric vein. Yep, scissors. Very good. We're going to get down onto the aorta. If I can find a right angle clamp, then you're going to grab the bovine. And I'm going to see if I can get us right down on the aorta. I think the aorta is right back here. Okay. Sometimes a bunch of lymphatics here. Come towards you a little bit. I think it's a little bit towards you. Let's not divide the IMA, that would be embarrassing. Okay, so that's probably the aorta. So now you take the right angle and you come up. So just there's the front of the aorta. Okay, that's good. Now tell me what you're looking for. You should always be thinking as a surgeon. Now you're thinking, I'm looking for the renal vein, okay? And it looks like you may already have found the renal vein. We prefer to see it from the outside rather than the inside, but you're on the renal vein. Now, as we come down here, we're starting to think about, I should be able to go continuously down the right common iliac artery here. Yep, beautiful. Okay, looks like we're on the bifurcation. Okay, so get your hand in there again, Dora. So I know Dora's going to remember. As a vascular surgeon, as soon as you start coming down the iliac artery, we are starting to think about, don't cut this on camera. I'll never hear the end of it. I don't think that's the ureter because that would be remarkably proximal, but you got to be sure. You should be able to run it right down the front of the iliac artery. Yep. So that's a free plane for you, okay? And if you can feel the iliac, then it's beautiful. Put on top of this, and you're making an S shape. How you make a wall with the S shape to lock in the bowel. Okay, so we've got nice exposure now. And we're going to have to open up the retroperitoneum just a little bit more. So with your third hand, open that up. So you can see how you can get one incision all the way down the front of the aorta, all the way down the iliac artery. Should be able to get down to the bifurcation. And I would really like to see a ureter down there. Now we'll open up that peritoneum a little bit more. There's the ureter. Okay, so that's the ureter right there. Okay. So again, this is critical, okay, because you don't, as you saw the anastomosis, you really don't want to be dealing with the bowel flopping on top of you. And so you got exposure from the renal vein, giant IMA, all the way down. There's the inferior vena cava, all the way down to the iliac bifurcation. So now we're going to set the self-retaining retractor. Say, what you want to do is put the post, you want to make sure the post is reasonably high. Usually the arms are out, so I have it right up against the arm. And it should be stable. So if it's wiggling around, it's not going to work. Then we're going to drop that down. And then we need the crossbar, which is that piece over here. This is not the newest of the Thompson retractors, but for a training lab, pretty damn good. And again, these have got to be high. If they're not high enough, by high I mean proximal enough up the patient. You don't want it to be high, making it deep. Low and wide. You actually need it more wide on the other side than you do here. Most of this retraction is going to be on Dora's side of this, like this, because then you can't get the other blades on. So put them so they don't interfere with putting the next set of blades on it. Okay, so you got to put these bad boys on. And so these bad boys kind of go like this, and they clip on. There's typically that one big wide blade that we put on. I'm going to take this off, turn this around. It gives me a little bit more length to pull on. And then we're going to press the button on the side. We're going to put that in, and I'm not sure I can say this to Dora, but I always tell the guys, don't have that thing stick in your groin the entire case. You go home with all these little blue dots. Yep. You're going to close up, but the assistant's got to be able to get in between these. You really don't want this thing sticking in your belly the entire case. And so typically I'll have one big blade here, and then up at the top we're going to have two blades. I usually use what's called a splanchnick retractor. We don't have that. And the splanchnick is nice because it's got a little hook on the bottom of these. So the key to this whole thing is up here. Typically I'll take another fold in. Yep. Lock it down. And then give me another. So typically what we use is a folded towel, because at the moment I need the kidney out of the way, and these are radiolucent blades. That's why they're black like that. We've only got a few of them, but it does allow you to bring an x-ray machine into this. Let's just walk through this now and show everybody what we've got, what the exposure shows. It shows the left renal vein beautifully. The gonadal vein is coming off here. There's the ovarian, there's the suprarenal vein. Gonadal veins down here, suprarenal veins here. And if we want to demonstrate this, you pick up, you're going to look underneath it, we're going to grab it, we're going to make that space, and we're going to basically take this, we're going to pull it up. Go ahead and dissect out this. Now this is vein, remember, right on it. Yep, good. Right on top of the vein. Beautiful. So there's the suprarenal vein, okay? It's pretty medial, and then what we're going to look for now are the renal arteries. Now again, you should know where the renal arteries are based upon the pre-op CAT scan. So we don't have to go dissecting all over the place, but I want to be able to show them. So go on the aorta. Good. Very good. So there's the left renal artery coming up, okay? Let's take that down. So this is probably a little branch. You'd probably cauterize that, but that's okay. We're going to cut it. Okay, so there's the renal artery. Now, and so you need a little bit more room than this if you're going to control it, especially if you're going to bypass it. So we're going to dissect that out a little bit more, right on the artery. Beautiful. Beautiful. So we're going to put another vessel loop around this. That's the left renal artery. We're going to double loop this. Okay, we're going to pass it one more time. Good. Lift up. So we're going to double loop it. That allows us to get some sort of semblance of control if need be. And so if you don't really want to tighten this down at this point in time, so what we'll do is essentially use We'll put a hemostat on all 4 of them. Yep. So that's the left renal artery. And then we're going to go look for the right renal artery. Dodo's off and running. So, okay, so we can't see the renal. That's probably it, but that could be, no, that's right there. It's actually posterior. This is one example of where really should have known this based upon the preoperative CAT scan. So, you know, we know from venous radiograph these things can be anterior, these things can be posterior. Excellent. Excellento. Okay, so this one is like a rock, so we're going to do the same. Depending on obviously what the operation is going to be, we're going to decide whether we're going to divide the renal vein, because we want to be able to get a suprarenal clamp. I cannot get a suprarenal clamp safely on this. Okay, let's just leave that for a minute and go down and get the hypogastrics. There's the bifurcation. Normally it's right at the origin of the external iliac artery where it is. We're going to come around behind this. Just put a hemostat in that. Now we're going to come in and do the left internal iliac artery. So now we got control of that. And if it doesn't come, don't pull it. I pulled it. Okay. Suction. Very good. Okay, so let's go over this side now, Doran. We're going to sew to the right common iliac artery, and we can basically get this kind of exposure here. Okay, so the artery's folded, makes it look like it's got a ureter on it, but it's not. And if you can see through it, you can cut through it. Okay, so there's the right common iliac, giant plaque there. And again, there's always a plane. Put your finger in there, Doran, you can dissect down. You always want to feel that iliac artery behind you as you do that. Okay, so we're down there. I'm not comfortable trying to sew to that, so we decide that we got to get better exposure than this. Okay, and let me just show you something. Okay, so this is tiger country for a vascular surgeon, but we might as well take this opportunity to demonstrate it for you. That you're looking at is the left common iliac vein. Okay. And that's probably the median sacral artery we just divided. And you can see how this is plastered. This is where you get May-Thurner syndrome, is right there. And the right common iliac is coming up. This is a bad place to get an injury. Okay, so we'll demonstrate that a little bit later. So now what we're going to do is say, okay, not comfortable doing a bypass there. I got to get exposure below. So that may be easier said than done. Dora's now going to grab the sigmoid colon, and we're going to develop the retroperitoneal plane. You can see the peritoneal reflection right there. Normally there's a little bit more of a gap between that and the sigmoid colon, because sigmoid mesentery is usually bigger than this. But this is how we're going to get into this space. Okay, so Dora's going to use her finger to nougat open that space as I cut it. You get your finger in here and just kind of gently open that up, minimize the amount of dissection we got to do. Don't let me cut the sigmoid colon. That will be a terrible assistant complication. So again, you can use a lot of your finger in here in that space. There you go. There you go. That's the space you want to be in. Okay, so you're going to move that back. You're going to keep moving that stuff back. Okay, so there's the space. And now you're usually feeling for the iliac artery. Obviously, most of the time we do this with a pulse in it. Here there's no pulse, but I'm guarantee it's going to be calcifying. Got to be pretty close there. It's really, I think it's right there. I think that's the artery we're looking at right there. Okay, so you kind of lift up and out with the retraction. It allows you to see this. And now we're actually looking at the iliac artery. So right now this is the iliac. So there's the bifurcation right there. So this one's a lot more challenging. Okay, so now you're going to get your finger down to, again, almost always you can sweep the peritoneum away from the front of both the internal and the external. So put your finger down there, and they've kind of already done it. I still don't know where the ureter is. Hopefully it's not in the bag somewhere, but again, remember this is a cadaver. Just gently come out, just as Dr. Wright was talking about this morning. A little bit, a little spread back out. Make sure there's not a big damn hole that I've made in the front of the common iliac vein. Okay, there we go. So I just find it easier to get something around the common iliac and then come back and get the internal and external. Obviously, you don't have to do that every time. There's a little bit of traction. That didn't really help. Yeah, go ahead, put it on. Yeah. So I tend to get the internal last, so use that up here. Yeah, just give me one of the. Good. Internal iliac aorta, strange branch up there. See how it's much more difficult. So you can kind of, sometimes you can retract this and get some of it from the, now we're going, there's the internal iliac artery down there. And of course you could do this much like you do a profunda and do it a safer way, in which case you punch through from here. Yep, and then I'm going to take the other end of it, grab that, and now you got control of the internal and external iliac artery. Okay, so if you're going to make a tunnel, then the tunnel comes behind the sigmoid colon. Go ahead and put your hand up there, Dora, in front of this, and go from above and below at the same time. So you'll be able to see the same thing. You've already developed that tunnel. Work your fingers till they come together. Yeah, there you go. So that's the tunnel. I'd usually put a red rubber catheter through it, and that's good. So that's a complete exposure. Now, if you're going to make a tunnel down to the groin, of course, we're remarkably close. Normally, be working from the bottom. You just go in front of that iliac artery. You don't have much to do. And on the other side, same thing. I mean, you got a little bit of tunneling to do there. Just don't go underneath the ureter on that side. Okay. You want to divide the renal vein? That's fine. Just give us what you got. It's a little awkward, but it's all the way up. So let me show you how I do it too. So I typically, once I've got it clamped, take mats the way. So you grab that proline. Yep. Okay. Go ahead and put 3 knots in it. 1, 2. It just kind of anchors it. You're going to come back to this. 3. Well, when are you sewing with this? So right on top of the clamp. Yeah, and you don't need to go behind it next time. Just come in front of it. Okay, go ahead and sew it. Take a bigger bite next time. Right on top of the clamp. Okay. Good. One more, and then we'll cut the rest of the vein. Way up there. Good. Yep. Yep. Good. That's how you want to do it. Exactly. Good. One more, and then we'll take it off. So at this point in time, typically I've got a big orange clip. I take the clamp off, I put an orange clip on there that controls any bleeding that exists, and then you're going to run this back, okay? Yep. All right. Yep. I'm trying. Okay. Okay. Yep, good. Now you're going to sew this up, or tie this up. So we'll get both needles off. Good. Okay, let's do the other side too. Get on the clamp. That means you get maximum amount of vein on it. 3 knots. Okay, good. So we take the longest one, give me the short one, whatever the short one is, probably this. Huh? Yep, and you start running that. No pressure. Okay, okay, thanks. Just going to run that down, and we're going to tie it. So again, you don't want to go back real far. We do not want to encroach on the ovarian vein and the suprarenal vein. Okay, good. And we'll help lay this down. Yep, make sure it goes down. We'll be talking about you across the planet. Yep. Okay, so now we've got, you can see both renal arteries, and then the SMA is going to be right in here. And we're going to take this down. The origin of the superior mesenteric artery we're coming right up on. In fact, that's it right there. And sometimes it's right at the level of the renal arteries. Sometimes it's not. I used to think in order to do a bypass, you had to be way up here, but that's the superior mesenteric artery, okay? Now, in order to put a suprarenal clamp on, we're going to be almost impinging upon the SMA, because this is where that clamp is going to have to go. So, there are a lot of branches. You don't want, it would normally take care of those because you don't want them bleeding. So, put your finger on either side, Dora, and you want to feel back to the spine on either side. Okay? And so now we know where the suprarenal clamp can be. And in this, you don't get a whole lot of extra aorta because of the location of the superior mesenteric artery. So we're going to get some aortic clamps just so we can demonstrate this. So that's a really, really nice dissection here. So this is a giant lumbar artery. There's another lumbar artery. So normally you ligate these. Why don't you just demonstrate ligating these things? So get one of those silk ties. Tying technique. I take it to me. Put another one. You take it to you. We both start tying at the same time. You tie it up. I'm going to be right in the front of the aorta, so you're going to give me a little counter traction. This is going to come right down from the aorta. Okay, your turn. So you kind of go in and out. Except I'm faster than she is. Supposed to be. Okay. Okay, so then you go cut, and then cut your assistance first, cut mine, and let's do the same thing on the other side, the other big lumbar artery that's down here. First, if I'm passing, take it to Dora. Yep, got it. Okay. Good job. Now again, one of the things, if you're going to do, let's say it's an end-side aorta bifurcation for occlusive disease, then it's worthwhile just spend a little time trying to find the lumbar arteries and clipping them before you get into the aorta, because that's where all the back bleeding is going to come from. So you can get pretty far around the aorta here. So go ahead and just looking back there. You got it. I don't see them there. There's one, probably one right, maybe one there, maybe not. Yep. The aorta wants me to cut that. She's moving along. Oh, looks good. No, I don't see many, to be honest with you. Let's just go down the IMA, because this is something you often don't see in an open surgery, but you see all the time when we're embolizing it. So there are the branches, okay? This is so when you're embolizing an IMA stem, these are sigmoid branches, left colic artery. This is where you'd come down with your microcatheters, bring the microcatheter right back up here and try and land them flush. Not so much flush with the aorta, but you got, you know, as you can see here, at least in this case, 4 centimeters of landing zone where you can put a coil in there. You don't want to lose the sigmoid branches. You don't want to lose the left colic. So again, there's the opportunity to see these things when we're looking at them in a cadaver. Okay, so I want to show one other thing, and that is, pull up on this. We're going to demonstrate the veins behind this, because this is where you can kill people. So here's the inferior vena cava, okay? And this is going to be the right common iliac vein. And we have a nice demonstration of trying to optimize the back wall of the aorta right here. Actually, in this particular patient, the vein crossed a little higher, cutting through the back wall, cutting straight into this. And that is a treacherous area to try and repair. The amount of volume that can be going through here is pretty dramatic. So again, here's left common iliac vein. This is where you get May-Thurner syndrome, is right here, right common iliac artery sitting on it. This is the other side. Pick up that stuff, would you? And see how stuck it is to the back wall? Ooh, it makes you nervous. All right, we're going to stop at this particular point in time, and then we'll continue from there. Good job.